Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for today's session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you are speaking. You can use *6 on your phone, or you can use the microphone icon on the bottom left-hand side of your Zoom screen to mute and unmute. You may also use the chat for communicating. We realize that question and answer time is important, and we try to categorize and address as many questions as possible during the sessions, but we follow up with any unanswered questions afterwards. If you have suggestions for future COVID-19 ECHO topics, please share via the chat tool, or you can always email us at echo@psu.edu. Please remember that no personally identifiable information is allowed when we're discussing patient cases. We are recording these sessions, and we share all materials and the recordings after each session. In the spirit of all teach, all learn, we'll be on a first-name basis during the session. For those who are new to Project ECHO, our ECHO sessions always begin with a brief lecture and are followed by either a case discussion or a question and answer period. Cases can include a question or challenge that you would want to address. They're a critical component of the ECHO model, and we always encourage participants to submit cases. The link to submit a case is always included in our follow-up emails. Today's session will include a brief lecture and case discussion on lessons learned in telemedicine and primary care, and that will be by Drs. Michael McShane, Daniel Schlegel, and Kit Heron. And this will be followed by a question and answer period. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State Health Online, and they'll help to field questions. But remember that this is all teach, all learn, so everyone can share both questions and answers. We will break after the lecture in case to address your questions, and then I believe we have extra questions for you. And with that, I am going to turn things over to Michael, Daniel, and Kit.
Thanks so much, Jackie. So I'm just gonna get us started here. So thanks again for everybody for joining us today. I'm just going to start off with a couple of introductions to ourselves. So I'll ask Dan and Kit to introduce themselves. So I'm Mike McShane. I'm assistant professor in the Division of General Internal Medicine, and I work at the East Campus here in Hershey, PA. And then I'm also assistant director of core clinical medicine up at the University Park campus. Dan?
Thanks. I'm Daniel Schlegel. I'm an assistant professor of family and community medicine, and I see patients at Middletown.
I'm Kit Heron. I'm an assistant professor of family and community medicine and the clinical informatician for University Park.
So as Jackie mentioned, today we're hoping to share some things that we've been thinking about as we've been rapidly implementing telemedicine within our clinics and primary care. And you know, as we were thinking about this topic, it's really, we wanted to recognize the fact that there's been so much work in telehealth and telemedicine platforms and within our institution and across the country. And even before COVID-19, if you look at the numbers, is upwards of 28% of practices have implemented some version of telehealth within a platform within their institutions. So, and we recognize that there is a significant amount of work to get these platforms up and running. So we are by no means experts in this. What we wanted to really provide with the group, and we felt might be helpful, was just to kind of give you our perspective as being sort of boots on the ground as we've been maybe in a lack of better terms, trying to control the chaos of rapidly implementing a new technology in our primary care clinics. So we feel like probably over the past 6 weeks or so, we've learned some pretty valuable lessons from trial and error, and we were hoping to kind of share those with the greater community. And as Jackie's mentioning, I think we all are kind of in this perspective that we'd love to hear how others are using telemedicine and telehealth so that we all can kind of grow and continue to make this a really worthwhile platform for our patients. So we wanted to first start off with a case to just kind of give, to kind of contextualize what the concepts that we'll be talking about. So I'm going to turn this over to Dan to just to describe the case.
Yeah, thank you. So this is inspired by true events, and it's not the most intellectually demanding case, but it does help illustrate some of the value of what we're talking about here. So an otherwise healthy 54-year-old woman was hiking when she tripped on a rock and fell, twisting her right ankle. She had pain in the ankle, but was able to walk home, though she was limping. She contacted her family physician through OnDemand and explained her history. At the time of the online encounter, she continued to have pain throughout the ankle and reported mild swelling on the outer part of the ankle. No pain elsewhere in her foot or knee, and she was still able to walk.
Thanks, Dan. So I hope what we can do is just kind of keep this case in mind as we're discussing, and we'll return back to it at the end of a couple points that we're going to go through now. So to give everybody sort of a basic agenda as the sort of main concepts and topics that we were going to discuss. So as is mentioning, probably over the past 6 to 8 weeks, we've been really working on implementing this new this telehealth platform in the primary care offices. And so what we felt would be really useful is to kind of give you a sense of some things that we've been really working on. One of those that we're going to start to kick off is just describe some key terminology and platforms that we've been using to give everybody a sense as we discuss further what that looks like. A framework that we've been using that I think has been really helpful as we've been thinking through this process is really thinking in terms of enrollment, implementation, and refinement. So those 3 key aspects. I'll show what that looks like initially and a timeline of events to give you a perspective of what we've been working on. And then we'll kind of delve into each of those aspects, the enrollment, the implementation, and refinement of things that we've been working on and give you a sense of the journey that we've been going through. So at the end, we have a couple of questions that I think we've been thinking in our minds and wanted to see what others were feeling like as well. And then hopefully will help to lead us into any further discussion and finally some wrap up. So we hope this will, at least sharing some of these lessons learned, will kind of give other folks and us an opportunity to really refine practices in the future and help with the telehealth platform. So before we really jump in, and I'm going to turn to Dan to give us a little bit of background on some key terminology and platforms that we've been using. But I wanted to outline a really important resource that I think we've found to be really helpful, and also helpful in a way of maybe describing things that we've been doing, but kind of sort of conceptualizing them. So this playbook was developed by the AMA, and it really walks through sort of what they describe in the analogy of as a game of a pre-game, during the game, and post-game, as kind of this idea of getting the telehealth platform ready, making it happen in implementation, and then refining it afterwards. So I would say if there's anything from this talk that could be useful, definitely check out this resource. And what we'll be doing as I kind of walk through things, what I'll try and do is highlight some of the terminology that's used in the playbook and then contextualize it to what we've kind of seen, how it looks like as boots on the ground, to just kind of give you a perspective from that piece. So a really good resource. So next, I'm going to turn it to Dan. Dan, do you mind just sharing with the group some of these key terminologies, the terms we might be throwing around during the talk?
Yeah, this has been something that I found, I think we've all found more confusing than I anticipated. So just to sort of lay it out, looking at the AMA playbook that Mike just described, is they describe telehealth as tools and platforms that allow clinicians to connect to one another and to patients, which may be synchronous or asynchronous. So telehealth is sort of the most broad category, and this includes clinician to patient communication and clinician to clinician communication. Telemedicine is slightly more narrow. This sort of tends to specify communication between patients and clinicians, and remote patient monitoring tools, blood pressure monitors, blood glucose monitors. And it also covers what we've really gotten into recently, real-time audiovisual communication, and also encompasses real-time audio-only communications. I have found these terms to be not very clear on their face, and it's led to a lot of confusion for myself and with others that we've been communicating with each other. I don't think the telehealth the term telemedicine are clearly different from each other on the face of it. That's led to some confusion. I think we've seen, I've tried to encourage the use of the terminology televideo visits to make it clear the video is involved in some visits, or telephonic visits to make it clear that there's no video component, that it's only a telephone component. It's been important to distinguish because we have found that we handle video visits differently than those that are audio only. For example, telephone visits are now reimbursing differently than video visits, and our schedulers handle them differently. Telephonic visits have been scheduled through our offices only, at least in our clinic, and televideo visits can also use the online platform. And it's when we talked about trying to encourage, telemedicine, and it told our staff to really push the telehealth visits. We mean the video visits, but we've discovered that staff thought that meant telephone or video, whatever they wanted it to be. So that's been a really important distinction as we've tried to encourage video visits. People on our own team are hearing, oh, telephone is just as good. So that's been one point that we tried to distinguish the difference between the two. And unfortunately, I haven't gotten any more clarity about an appropriate nomenclature for that. If anyone else has got anything like that, I'm really eager to hear it because I think that would help us clarify some communication challenges that we've had. Locally within the Penn State Health Network, there was some initial confusion as well that this would be more relevant to those using our platform. So I'll just go over it quickly to those that are not using this platform. The vendor we are using is American Well, also called Amwell, telemedicine company based in Boston. The product that they give us that we are using as the platform is called OnDemand. And the specific platform that Penn State is using is called Penn State Health OnDemand. And within that, there are sub areas which structure patient care differently within OnDemand. So I can show that, I think, in the next slide. The three different services that Penn State Health's been supplying through the OnDemand platform are coronavirus screening, urgent care on demand, and virtual clinic. Patients can access any one of these three areas. So coronavirus screening was set up very rapidly, was staffed by our institution generally. There's been a team of folks working really hard on this, and they're just doing coronavirus screening and ordering to anyone that wants the service. It was a very broad, open service. Through the same platform of OnDemand, we've been providing urgent care that's been provided just by family medicine physicians within our Department of Family Medicine. And that's for anybody, anywhere that wants to access our urgent care from 6 a.m. to 9 p.m. And then the third is virtual clinic. This has been going on for about 2 or 3 weeks now. These are scheduled visits that we have so that our own patients that are established with us can see their own provider. And they take progressively more effort on the part of staff. Doing coronavirus screening has not involved our office staff at all. Urgent care on demand doesn't really involve much scheduling on our staff. It's sort of a patient shows up in the waiting room and we see them as a provider. Virtual clinic has been a lot more complicated trying to make patient care schedules work with the provider schedules. But they've all served different purposes and have illustrated different ways that we've been able to use telehealth or telemedicine as a platform.
Thanks, Dan. And, it's been, so I hopefully all these terms I feel like are sort of jumbling around in my mind and it's hard to keep straight. So I appreciate going through that. We'll hopefully, as time goes on, we'll try and clarify as maybe it'll make sense as we're kind of discussing these timelines and then delve into each individual parts. But we wanted to kind of take a moment here and describe kind of where we've seen our journey begin and kind of continue on. So I was going to give a brief overview of really, although telehealth and telemedicine is not necessarily new to Penn State Health, our institution, it's this rapid infusion that we've had in primary care is new. And so there have been some really unique things that I think we can glean from that process of rapid involvement. And like I was mentioning, it's pretty crazy that it's been over about a month and how much has gone into work in creating these opportunities for patients to access the telemedicine platform. So this is a timeline from March until where we're at now, April 23rd. And just have this a little bit of a pictograph to give you a sense of where we're at. So what I do kind of roll through this idea of enrollment, implementation, and revisions and refinement. So really, our process got jump started for a whole host of reasons, one of which I think was a major concern of what happens if some of our providers are in quarantine. How is there a way that we can sort of help them still be able to interact with patients and so that our access doesn't drop dramatically. And then as time has gone on, the need to limit the amount of patients in our office has led to the need of needing to have more opportunities to replace the face-to-face encounter with something different. So we initially began, in terms of primary care, family, community medicine, and internal medicine, began initially to try and target those physicians that might need to be in quarantine. And family medicine really took a lead in helping to get folks enrolled in the urgent care version of the piece that Dan was mentioning before. I think what was really valuable about this is it created a group of physicians that were almost like super users, that were able to kind of share the platform and the intricacies of it to the greater community. So it was almost as if this initial sort of impetus to get physicians enrolled and using the platform really helped for us to create a sort of a core group of super users. Then around mid-March, I think much of you are probably aware of the change in the CMS guidelines and the implications of that on reimbursement, and really kind of jump-started, in addition to the timing of needing to have less patients in the clinic, to start to expand and think about the virtual clinic as an opportunity to replace some of the face-to-face encounters that weren't necessarily happening for patients. So in the Division of General Internal Medicine, we initially started off with a small pilot as workflows were being established, and then sort of initially broadened the enrollment. So as you can see, I kind of created this graph that shows this kind of triangular shape as sort of enrollment began. At the same time, we started to create these daily team huddles. This was a group of primary care group that were more on the ground, daily huddles that were primarily focused initially on the concept of enrollment, of how can we help to get our physicians enrolled. And it was a group of multidisciplinary group, including IT and education and nursing. I think that really helped for us to kind of troubleshoot on the fly as things were coming up. As time went on, as more physicians were getting on the platform, it was almost as if we reached a critical mass, and those conversations in Daily Huddle really shifted towards implementation and ideas about what we needed to do to make sure that this worked. So I think ideally in a situation, you'd love to get everybody enrolled and then implement. Ours was kind of a phase in for both approaches. In some of these discussions, I think we spent a lot of time talking about workflows, for example, and really became pretty noticeable early on that was really critical. Also, what we found is that it almost seemed like on a day-to-day basis, so I'm sure many of you are experiencing that things changed and we needed to modify the workflows and different aspects of implementation as time went on. So that really kept us busy for a while of refinement. And then finally, we started to shift towards this concept of refinement, of weekly meetings, starting to think about what does telemedicine look like best for primary care and our certain patients within the context that we're doing. So I kind of draw this as a steadily gradual increase. I think we're still in that process of continuing to implement and then also refining the process as we're sort of going on. One thing that I do want to say that's not necessarily represented in this graph is the enrollment of patients and adoption. So that has been something that we'll sort of turn to later on, has definitely been an additional challenge of getting folks on board and unfamiliar with the platform. So I wanted to turn to the three kind of concepts of enrollment, implementation, and refinement, and then begin to describe, as we were rolling out that process, some lessons that we learned. And as I mentioned, we've been sort of using how the AMA Playbook has conceptualized these concepts. So in terms of enrollment, there are probably three major lessons that we learned in that whole process. So I'm going to outline them here. So the first critical step that I think was really helpful for us was, as I was mentioning, those daily huddles was a really important step. So getting the right people in place that could help to enroll different providers, and then ultimately with implementation was really key. And it really helped us sort of identify any workflow barriers or things that might be an issue for enrollment purposes. And so that team that met every day was so helpful to troubleshoot problems as they arose. The second thing that was really helpful, I think, was to pilot the telemedicine platform on different providers with different expertise. So there's sometimes it was easy to go to those people that are more technologically savvy in understanding the platform. But I think what we found that was really useful was to also engage with our providers that might have a little bit more trouble engaging in the platform, and work with them to figure out what sort of barriers would exist and ways to help others feel more comfortable with the platform. And so not necessarily focusing on those early adopters, but a broad range was really helpful, I think, from a troubleshooting perspective to gain some insight of how to make it work. And then the final thing with enrollment that was really helpful was identifying and prioritizing resources. So one thing that it's sort of, as we've looked retrospectively, that I think would have been helpful initially was trying to think of what hardware and technology is really needed to make this work. So internal medicine, we have a challenge with some shared workspaces, and it's hard to keep those types of encounters private. So thinking about technology needs such as cameras and headsets and those sort of issues. I think what we also found is that with the enrollment process early on, a significant stressor on the IT infrastructure to help get what seemed overnight hundreds of providers enrolled in the telemedicine platform. And so recognizing that there's only 24 hours in a day, they were seriously taxed by helping us to help with the providers getting enrolled. And so in retrospect, I think that was one of the things, if we would have thinking about how to identify what resources you have and how to prioritize is such a critical step in that early phase of enrollment. So in terms of implementation, it was almost around April, or that transition, where we seemed to reach a critical mass of providers that were ready to go and were starting to use the platform. And so I want to shift now to a couple of lessons learned that I think are related to the implementation phase, and in similar keeping to the language of the AMA playbook. So there are three major ones that I wanted to review. The first one is about designing workflows. Gosh, we almost retrospectively, after implementing it, I think came to the conclusion we really need to have some good workflows in terms of how does the front desk staff schedule the patient, how does the nursing staff work with the initial med reconciliation, all these little pieces, and even thinking of scripts that would help coach the patients through the process of enrollment, really critical pieces of information, and was really helpful to outline some of those workflows and then implement them and make modifications as time went on. So that was a really important piece that I'm glad we did, and I think was also kind of a important next step for us. The next thing about preparing the care team. So this was another critical element, I think, of the platform. So enrollment is half the battle, and then I think there are training modules are helpful initially, but you can't underestimate the power of experience. And so I think what we found was it was really helpful, for example, to create a fake patient and basically schedule each of the providers with a fake encounter. And so just kind of walking them through of what it looked like, and also seeing what the platform looked like from a patient perspective. We found that oftentimes that as much training and background helps with the patients initially, there can be some questions about how the technology works on the back end. So sometimes the providers would be getting those questions, and seeing what it looks like for the patient had been really valuable. And then the final piece for implementation is having a plan B. I think what we found out pretty quickly is that with any technology, we can run into issues with the platform not necessarily working or having audio-visual issues. And so having a plan B for us, using Zoom as an alternative, and then as a backup for that, a telephonic visit, was really key. And it would have been helpful in retrospect to have some of those in place and going from the start to kind of help people get more comfortable with the system. And then finally, so I wanted to talk a little bit about refinement and sort of next steps. So this is, I think, maybe where we're at right now and things that we're thinking about. And so this would be great to hear what other people are working on and how they're thinking about this. So I think as we continue to implement, there have become these almost different parts of the system that are really pinning and seem to be opportunities for growth and development. And we've been really, I think some of us have been really kind of thinking in the mindset of the quadruple aim. And as we're thinking about the telemedicine platform and creating different systems in places, there are a way to improve patient outcomes, a way to improve the patient experience. Is there a way to reduce costs? And at the same time, with any technology, to avoid any unneeded burnout or significant stressor on our care teams. So thinking in the context of that. And there are 4 things that I think we've really kind of landed on so far that are still in a work in development, but things that we're thinking about. And the first one is partnering with the patient. So this is what I was kind of referring to earlier, that this platform for a lot of our patients is new, and overall adoption has been variable. Feels like the telemedicine is such a great opportunity to increase access, and that feels like a huge advantage. The one piece that I think we're a little bit worried about is, in particular, certain populations that are more vulnerable due to technology. So our elderly patient population and those with lower socioeconomic status, it requires having a computer with web, audio-visual tech available. And I sometimes worry that as we're rapidly implementing this and possibly, creating more access on the telehealth platform, are we reducing the possibility for some of those patients to engage with care, those that probably need even more access than others. So it's a little bit of a concern. We have noticed that with our family community medicine colleagues that the mean age for patients using the urgent care platform is definitely on the younger end side of things, but that's not that patients are younger overall. There's a broad range of patients that are interacting with that interface. It's just thinking, I think, a little bit more about how do we help engage for those certain populations that could really benefit from having a couple more touches in their care. The next piece that we've really noticed is thinking about alignment with current asynchronous work. And so Kit has been doing a lot of this up at University Park campus, and some of our providers are also noticing this. How often do we get very lengthy portal messages or have some really important lab work that probably would be better to have an actual visit with the patient? And sort of thinking, is there a way that we can use the telemedicine platform to have that opportunity to speak with a patient on a virtual visit rather than having another office visit or having nursing staff call them. So, and I think from Kit's experience that this has been really beneficial for the patients to actually speak with their physicians, and has also been beneficial for explanation and making sure we're communicating appropriately with patients. It feels like there's a really good opportunity to align some of the asynchronous work that we do that's not necessarily reimbursed with this telemedicine platform as a way to sort of have an opportunity for reimbursement. So that's something else that we've been thinking about. The third major thing is about symptom triage. So this comes into play especially with the urgent care appointments, and then patients where you're uncertain if it would be helpful to come in for a visit or not. And so it really feels like this might be a really good opportunity also to help patients get more comfortable with the telemedicine platform in terms of enrollment from the patient perspective, but then also have a couple more of those interfaces with a physician to help. There's a really added benefit of seeing a patient and virtually speaking with them. So I think one that has always come to light for us is a patient that might have a case of cellulitis, and then having that opportunity to reevaluate them on a virtual visit rather than having them come in. This is particularly too, as I was mentioning, for the first point of those vulnerable populations. Is there a potential that we could save them from requiring they need transportation to come in the clinic and those sorts of ideas. So we've been starting to really kind of think about like that as an aspect that might be really important for telemedicine refinement. And then the final thing, gosh, so as I was mentioning, so many people working hard in different departments to make this happen. I think we're finding is there's so many really good resources. Working on a way to help standardize that across the institution, really, really key. There's so much probably duplication or refinement that's happening. A way to kind of share those best practices seems like such a critical step as we're kind of moving forward this and thinking about next steps. So those were the main points of refinement that we've been thinking about for next step. So I want to turn it back to Dan to briefly remind us about the case, and then maybe we can share some points of how we think it might be related to some of the things that we've talked so far, and then was going to open it up to any some questions that I think we've had for the group. So Dan.
Sure, thank you. So our patient who hurt her ankle, after obtaining the history via OnDemand, her physician proceeded with physical examination, asking her to move her phone to inspect the area. He was able to see that she had mild swelling over the right lateral malleolus. Her active range of motion was slightly limited with eversion. He directed the patient on how to locate the lateral and the medial malleolus herself and to palpate the sites. She described tenderness at the lateral malleolus. Only on the right, that should say. She had no tenderness over the base of the fifth metatarsal or the navicular. The physician determined that an ankle x-ray series was necessary based on the Ottawa ankle rules. He ordered the tests and she proceeded to have the imaging done without an in-person encounter. The x-ray was negative and she was ultimately diagnosed with an ankle sprain. This sort of demonstrates how she was able to access care quickly. And then this was able to avoid, a face-to-face visit, which is what we're kind of trying to do right now to avoid the risk of contracting, of passing along coronavirus. Physical examination is an important part of this workup, and they sort of found a way to do it remotely. The patient found her own tenderness on examination, which led us down the pathway of needing the x-ray according to the Ottawa ankle rules. So I think it sort of neatly demonstrates a way that the urgent care or the on-demand application really did help out the patient and the provider.
Thanks, Dan.
Mm-hmm.
So before we move into discussion questions, does anyone have any questions or input either on the case or the information that was shared by our team today? And again, feel free to unmute your microphone, or you can put information into the chat box. If there aren't any questions around the case or input on it, we can go ahead to the next slide. And if you want to lead us through those discussion questions, Michael, that would be wonderful.
Thanks. So as we're, I'd love to hear everybody's input on this. I think when we were preparing for this presentation, there have been these questions that have been rolling around in our heads. And so we have this listed here as a couple of questions that I think we're kind of working through and thinking about. So one of the questions I think that we're really thinking about is kind of related to this, the final points of thinking about what does telehealth look like in primary care post-COVID? So, and sort of the second question related to that of reimbursement is, what's going to happen in terms of reimbursement ultimately after the pandemic has passed? So sort of these as both being related to it. I think probably extrapolating that too, and love to hear other people's thoughts, is there probably other in other departments thinking the same thing of what will it look like. Reimbursement plays a huge part of that. So definitely a question that we've been pondering. Somewhat also related to that, and I think all these are kind of related to the post-COVID, is what do we need to do to physically transform clinics if that will kind of help to fit with the telemedicine platforms, the physical spaces that we have in departments, what are the needs for that to happen? And then for those ahead of us, yeah, I'd love to hear any opportunities or things that you've noticed in terms of lessons learned. And I do see a question here in the chat. And so Dan and Kit, please, definitely correct me if I'm wrong. I think the way that we've heard from our institution is in terms of protecting health information and then also privacy. The Amwell has been the main platform, and then as an alternative that we've recommended is to use the Zoom platform that's HIPAA compliant through Penn State Health. So that's been the backup. I think in terms of privacy is probably an issue with FaceTime and some of the other technologies. But Dan and Kit, do you have other thoughts?
I'll chime in real quick. Absolutely. So first off, why Zoom over FaceTime? As a backup, Zoom has a significant amount more cybersecurity protections than FaceTime does. Not to say that FaceTime is an open book by any means, but Zoom has a significant amount of protections built in against things like Zoom bombing, identity theft, which could happen whether or not you're talking to a bad actor in the first place. Additionally, from a more practical perspective, reimbursement-wise, payers are very clear that CMS is very clear that right now it's the Wild West. We understand you need to take care of patients. FaceTime can be appropriate. Zoom can be appropriate. But following that, that is likely going to go away, and they're going to go back to wanting HIPAA compliant, secure, encrypted, integrated channels to do patient contact. And so if you lean on those services that would not normally be integrated into your EHR, into your workflow, you then set up this thing that must change again, and you must redo the entire process for this. So that is kind of why not other services that might on the face seem easier.
And the two new questions that came in seem to be related both to patient reception and patient access. So Michael, can you facilitate those?
Yeah, sure. And Dan and Kit, I'd love to hear your experiences with patients access. I want to say one brief thing about access. And yeah, gosh, I think the thing that really worries me is this piece that I was mentioning earlier, especially for those patients that are more vulnerable. Are we at risk of, because the way that telehealth is being implemented, are we at risk of making that access even less available for them? i.e., patients that are elderly that might have a little harder time with technology. We start to block off clinic time that's telehealth. Are we limiting their opportunity to come into clinic? This might be a overblown fear, but that's the one thing I worry about. And the same thing true with lower socioeconomic status of really does require to have a smartphone or ability to use a webcam. And I worry about, those patients will just the knowledge of knowing that telehealth is happening, will it make them less willing to engage with care? So things that definitely consider. I just want to throw that out there as something I've really been thinking a lot about. Danny, Kit, other thoughts about what you've seen from patients and how to alleviate any concerns?
Yeah, no, I wish we had a better sort of rural infrastructure for rural broadband. I mean, that's actually could be becoming a health issue, the lack of infrastructure access to this patient, which is exacerbates the problems that are already there for communication. One thing that I found is interesting in this process, you mentioned enrollment earlier. We thought that the bottleneck was enrollment of physicians. We were so eager, and we were really beating down the door for IT, like, please get us all enrolled, get us all trained immediately. We got to get out there and see all these patients. And there was this mad dash to get everyone enrolled as quickly as we possibly could. And we got enrolled and ready. And there's not that many patients there because of this. I think because of these comments you're making here about patient adoption, patients not yet comfortable with it, patients probably deferring healthcare, thinking that, oh, next month, everything is going to go back to normal and I can do my inpatient visit that I'm used to. I suspect we're going to see a delayed adoption of the technology for as long as we anticipate, for as long as the public believes that next month things are going to be back to normal. And I think that's why they're delaying adoption of the technology now and the behavioral changes that may go with it. And if that next month keeps going on for 6 months or 12 months, I think we might continue to see the delay of patients adopting the new technology.
I'm going to hop on the back of that, Dan, as well. And a lot of this, too, is perspective on how much effort and time it takes to engage with the new technology, if it's available to people. I think once people have engaged in it, the barrier drops significantly. I've been comparing it to, it's basically your doctor's appointment bleeding into the drive to the physician's office. So if it takes you 15 minutes to drive to an office, I can set you up and it'll take you 15 minutes to set up. But then you won't have to drive to the office, and next time you won't have to drive to the office again and again. And so really emphasizing that activation energy barrier of, yes, this is going to take a little bit of a lift, but once you've made that lift, I've had patients continuously re-engaging through this process. So really just the perspective of, yes, it's a lift, but it's not any different than the lift that it would take to get in the car and get to see me physically. You just have a different lift.
And I think this is again, it's purely anecdotal evidence of a patient that I recently saw who had had challenges with engaging with the telemedicine platform for 2 previous visits, and had this mindset of giving it another shot and kind of continuing to work on it. And we had a great telemedicine visit, and I think afterwards he even reflected to me of how glad he remained on board and continued with that. So in the back of my mind, I think as we're continuing to expand and work with our patients to work on this platform, that's one of the things I think I'm going to share to my patients of saying, oh, we've seen this before, stick with it. This is going to be really useful. And I hope that, the patient that had seen down the road will continue to engage in the platform.
So there are quite a few questions and comments coming in, and I'll try to get us on track with them. I'm pretty certain Christine's question around expanding with patient reception and also Lex's regarding access have been addressed, but if not, either of you could go ahead and put that into the chat again. Heather did mention that they've experienced a significant increase in client attendance and appointments through the use of telehealth, and they have 2 very rural clinics. Those clinics have increased in volume by 50% from 3/18 through April 1st. And then Akshay has indicated a little bit about the difference with telehealth in India in terms of third-party software. This government has started web-based telemedicine can be used on any device. And I might let you come back to that. Let me get these all out, and then we could you can prioritize. So why don't you talk about what's going on in India, and then we'll come back to these other ones quickly. So I don't know if there's anything else to share around different types of telehealth being, happening in other places, if we have other individuals on from other countries as well.
I can chime in on this a little bit too from just a tech perspective. One of the major challenges in any of this is the enrollment adoption period. Once you have it adopted, then the implementation and the customization periods tend to be the things that boil down to clinic-based workflows and all of that. And that's really the large cognitive lift. The idea of having a single standardized platform is one that has been welcomed in particular settings. See the VA, who has a universal EHR for all of their systems. It may not be the best system to interact with, but it's standardized, so you always know where to expect that. The US government is implementing FHIR criteria, which is a progressively more stringent criteria every year for interoperability. So the hope is that we will eventually come to a standardizable platform, which, though still third party, will allow for a same platform feel in our current system. So as much as I am exquisitely envious that India has a single platform, and I am, I look forward to that in the next few years in America as well.
Well, ironically, one of our questions is, how do you envision the future of digital health or telemedicine? And I'm going to kind of take that back from very futuristic to some people are commenting that, with what's going on with COVID, it would be foolish to allow telemedicine to falter. This is an opportunity to move it forward. So can you talk to that a little bit about the future?
Yeah, gosh, yeah, loaded question for sure. I might hedge and see, Dan, do you, or Kit, do you guys have
I have all the answers for that one. Yeah.
any thoughts right now?
I think that to the discussion question about what happens with reimbursement, as so often happens, that controls what we do. And if I think that I love the comment here about that patients being advocates for the new system and encouraging reimbursement of telemedicine of video visits potentially at the same level as office visits as they do now. If that happens because of patient advocacy or otherwise, that will make it be adopted widely and stay. And I think that you're right. If that doesn't follow, I think we're going to see a regression to the old way of patient care, of in-office visits being the main way we do patient care. Whether that's good or not for access, for quality, I don't know. But I think that reimbursement will drive behavior.
You know, the one thing that I keep going back to is that IHI quadruple aim. So I you know, in my head, with any new technology or opportunity in medicine, I keep trying to think of in what way can it provide benefit in all of those types of categories. And so telemedicine, you know, at least initially on the surface, there's a, you worry about the physician well-being, the care team well-being as a part that could be impacted by it. And so in what ways can telemedicine work for us? And at least on the refinement slide, we were kind of mentioning different things that I think that we're starting to see. Maybe there are certain patient populations or types of conditions that are better handled on the telemedicine platform. One thing that has been hugely helpful in the AMA playbook, they describe a little bit of, in terms of especially behavioral health, as being an opportunity to provide more access to patients rather than an in-person visit. And similar to, there are certain things within our clinics that I think would be hugely valuable for patient populations. For internal medicine population that I think would be in need of more touches are those patients that are in nursing care facilities, assisted living facilities. Gosh, what a great opportunity would it be to be able to create a system in place where our patients that are in different places and institutions have this opportunity to have a more frequent touch, to do some of that symptom triage essentially of a patient. Definitely more valuable to kind of see it in action. A recent visit that I had too was exactly that case of a patient who was concerned for developing either a cellulitis. And so having the opportunity to visually see that patient when they couldn't access the clinic was such a value. So in that aspect, in the quadruple aim, it feels like, you know, that helps with the patient experience. It helps with better outcomes in treating a cellulitis now before they need to be hospitalized. And then it's just more getting comfortable with that platform and trying to figure out ways to integrate it into the clinic. So at least that's where my head's at with that.
And Marina mentioned that they're seeing a lot of benefit with regard to mental health visits that are being done. So thank you for sharing that one. There are two kind of resource-related questions. Someone was mentioning, I think it was Kelly, regarding potential for development of free smartphone apps to measure some vital signs. So do any of you have any input on that? As well as, are there any good educational resources available for how to perform physical exams through a video platform?
So I would welcome any direction about about physical examination. What I found was not really evidence-based. I think this is probably an area ripe for exploration of the evidence. But in my view of resources out there, I couldn't find anything that was about evidence-based physical exam resources. I think that there are some tools being created out there. I know of at least one tool that is sort of like a tricorder from Star Trek. So yeah, so some of you will appreciate that, but it sort of measures several different vital signs. It can be patient, a handheld device. It's like $100 or so, and I think it's up for potential FDA approval this summer. But then there may be other ones like that out there that I don't know of. But if that existed, if that got approved and was reliable, that could be a really rich resource. At the same time, it would take us time to figure out how we use it, because I understand the concept, but how reliable it is, how useful it is, how is patient compliance with it, or adherence to proper usage of the tool, I don't know, and that would also be another area ripe for explanation.
Thank you. And if anyone is aware of any others, please feel free to put them into the chat. There's a question from Sharon, and I believe it probably goes back to your lessons learned, but how many of the televideo visits needed to be converted to in-person visits, and what types of diagnoses were these?
Yeah, I'm sure Dan's chuckling because, oh gosh, Dan has been yearning for some data.
Well, I'll share here. So let me tell you something. So when Mike and Kit and I were preparing this presentation, we were going to do like a video simulation. And we had, I think between the different times we tried it, at least 3 dropped conversations in our simulated conversation to show you all the best practice. And that was the 3 experts here trying to make it work and demonstrate best practice. So you didn't see that today. We're working on something separately, but it is not an uncommon occurrence.
Yeah, and I think that information would be so valuable too, especially as you're thinking about rolling it out. I don't think we've been able to really capture that yet, but gosh, how critical and important that information could be to help planning forward and thinking about how many times are people needing to use an alternative version, or even in the situation of, I think if you start to develop refinement of it, and let's say, for example, a clinic sets up a way to do symptom triage, it'd be really useful information of how many of those symptom triage visits required an in-person visit, and how many of them ultimately didn't require the need to come to access a higher level of care. That data, at least that's where my mind was going, would be really helpful to kind of figure out as we're moving forward. And the playbook, what has been really helpful, the AMA playbook describes, of other things. One of the things is really that important piece of evaluation. So making sure you're moving forward, it's like creating those mini PDSA cycles as you're moving forward. And that piece, I don't think we've really, as we've been rapidly implementing, haven't really been able to capture that data yet.
Okay, thank you. There's another question. So University Health Services at Penn State, major issue has been established patients have frequently traveled home to out-of-state settings, which has complicated each step of the workflow. Are there any suggestions for that?
So I can try to field that, as I've been trying to do boots on the ground workflow for our practices up here. The issue with this is you're attempting to replicate in telemedicine, you're trying to replicate a physical process through a medium that doesn't allow that thing. So you're trying to come up to a closest comparative entity. So our difficulties here have been many, as long as we've been looking at it from like, how do I fit you back in the bucket? Once we've our best successes for workflow so far have been letting go of okay, we have to do it and forgive me for speaking in vagaries, but the idea of separating yourself from like, I need to get them, like they need to be checked in, evaluated by a nurse and have their med rec done, be evaluated by a provider, have the ordering done, things like that. Trying to replicate our original process was extremely stressful because we couldn't figure out how to because we ran into those problems. You're gone, how do I get this here? How do I get that there? Starting from scratch, where are you? What do I have? And then what resources can I implement to move that forward has taken that stress off a little bit. It's still not easy. And if you'd like to talk offline about more of that and try to tailor that, I'm happy to try to help.
Thank you. Thank you for that response. So John has given a comment, and it might go along with some of what Jim Hayden has been saying, but telemedicine, like the telephone, it's just one more technology to increase communication. John's grandfather, a GP in the 1910s, initially considered the telephone an interruption in his life and work. So I think we're reliving that.
Some of that hasn't changed.
So we do have another question here. When establishing new patients into your practice via telemedicine, how long do you think you would feel comfortable caring for a multi-morbid person until you'd want to see them in person, given that there are no acute issues arising?
Go ahead, Dan.
I don't have an answer to this. We've debated this. Our group has decided that we should allow new patients into the practice via telemedicine only visits. I've been more reluctant to do that. It's a debate between access and being available for new patients versus the thoroughness and the value of sort of an initial face-to-face visit and physical examination. For me personally, I'd say not at all. But clearly, but I don't want to, but that would also potentially deprive patients of access to care, which I also don't wish to do. So I don't.
Yeah. You know, the concept, the thing I'm just thinking about is like there's the patient physician relationship. There's a lot of trust that goes from the patient to the physician. And probably in this setting almost highlights a little bit of a trust that goes from the physician to the patient, and trying to partner and figure out what's going to be the best plan of action to keep them healthy. And especially in times like this, there's such a huge risk benefit ratio that's going on, and trying to think about balancing that for the patient. It's such a tricky question, and I'm glad other people are struggling with it too.
Can I jump in to answer?
Oh, please do so.
Hi everyone, I'm Dr. Farooq. I'm one of the nephrologists. So I use telemedicine to see an 84 years old new patient very recently. And I think she was so happy that I was able to see her, because her, there were some issues with her kidney. So she was really scared that if she will go on dialysis, and this is in the middle of COVID. So I see this in two phases. One is like right now, we do have some patients out there who need or want to be seen very quickly. So this is like really your front end. Maybe it's a virtual front end. You can actually triage them. You can see them. Like then you determine, okay, maybe after a telemedicine visit now they need to be seen in person. Then you can, bring them back. But I think for future clinics who have like 100 days or 200 days wait time, I think this will really help to maybe triage some of the patients by a separate team, like a modular team, maybe a team of physician and APP and resident, and really triage some of those patients. And at least, the first visit is done, labs are done. So maybe like a screening or a pre-screening kind of a visit, and you keep the cart rolling. So I see a lot of, future implications of this technology beyond COVID, season. So I hope that this stays a season and it gets over soon. I think, again, I feel one size does not fit all. Surgical patients, medical patients, cancer patients, rheumatology patients, everybody may have some different needs, and how are we going to address their needs? I think I see some value of using this technology.
And I was just thinking, thanks for bringing that up, Umar. We were talking about symptom triage. It's almost like in primary care thinking of the asymptomatic triage, and this might be to Kelly's question about that person who's seen once a year. Yeah, it's kind of interesting that as that AMA playbook describes the symptom triage, maybe it's also thinking in light of those asymptomatic patients. What can we do to help them stay healthy that may not necessarily require them to be in the clinic in person?
Yeah, I can echo that and say simply that, I view this as a really great tool to give the physician or the provider another layer of triage, because if you asked me the same question in January, hey, what are you comfortable with evaluating over the phone? How often could you evaluate someone over the phone before you bring them in for a physical appointment? I would go, who are we talking about today? And so I think having that extra threshold of like, well, there are some patients I would be comfortable doing that with. There are some patients who I am extremely uncomfortable with that with. And just giving the provider the capacity to say, maybe I don't need to bring you in January in a snowstorm, but I still want to talk to you, and I think we can do that.
You know, I think this kind of lays bare some of the absurdity of our fee-for-service system. I think, you know, instead of just taking care of the patient, I've got a situation, I got a very brief electronic message that a patient has had UTIs before, has symptoms that she thinks is a UTI right now. And that was pretty much all I got in the message. And I sent a message back to, you know, through my nurse, please call this patient, get more detail, you know, how long it's been going on, what are the symptoms, so I could have something more concrete to go with. I was also faced with the option if I could have this patient come in. So I had 3 different ways to manage this. If I had just said, oh, the person who took the message and sent it back, I could just send in a prescription for an antibiotic. They probably have a UTI. They know their symptoms, and they probably know what they have. That would have been 0 reimbursement. I could have had the nurse call back to get more symptoms, or I could have called back myself and gotten some reimbursement, or I could have had the patient come in and get something like 3 times the reimbursement as the phone call would have been, or the virtual visit. And the patient got the same care, but it's this having them come in or get care in a certain way, whether that's most appropriate or not. It just, I don't know. I've been reflecting on that lately. I'm not sure if others will see it, but it's the same service, and my behavior could be driven by reimbursement in a way that, again, the new options that we have kind of, I think, lay bare some of the inadequacies of the current reimbursement system, which I should not make a comment like that with 2 minutes left. I'm sorry.
And with that, we do have 2 minutes left. There were a lot of questions and comments coming in. So if I missed anything, go ahead and put it into the chat, because again, we can have a follow-up via email afterwards. So if there are any final questions or comments, now is your time. And I would like to thank everyone for participating, especially, you know, Daniel, Kit, Michael, you've done a great job. Thanks for those who contributed to the conversation. A few quick reminders before we end, that if you attended today and are interested, you can collect CME credit and you will receive a survey. You can use that survey, 1 for each session. You can use the same one every time you attend a session. Again, all materials will be shared via email. And finally, we hope that you'll join us for our next ECHO session. This one is for skilled nursing facilities in particular, but it's at 4 p.m. today. And the lecture and discussion will focus on, you have your first positive. Now what? What are the next steps after your first COVID patient? So we hope to see you again. Thank you.